So welcome everybody. This is a clinical education webinar / seminar on virtual reality for exposure therapy in social anxiety disorder. And we are very excited to have Dr. Andy Rosen and Dr. Eric Spinner here to talk to us today about the work that they're doing in this area. My name is Taylor Wilmer, and I'm an associate of the National Social Anxiety Center and a board member and director of therapy at InStride Health. And I'll share a little bit about Dr. Rosen and Dr. Spinner, and then we'll get started. So Dr. Andy Rosen is the founder and clinical director of the Center for Treatment of Anxiety and Mood Disorders in Delray Beach, Florida. He's also the co-founder of the Children's Center for Psychiatry and Psychology and Related Disorders. And he's board certified by the American Board of Professional Psychology, is a clinical fellow for the Anxiety and Depression Association of America, and a diplomat and fellow in the American Academy of Clinical Psychology. Dr. Rosen was also appointed a clinical affiliate assistant professor at FAU College of Medicine, and he's a board member of the National Social Anxiety Center. And Dr. Eric Spinner is a postdoctoral fellow at the Center for the Treatment of Anxiety and Mood Disorders. And he specializes in individual therapy, partner and family therapy, and group therapy across the lifespan. He received his PhD in clinical psychology from Nova Southeastern University and completed his clinical internship at the Renfrew Center for Eating Disorders in Coconut Creek, Florida. He specializes in providing evidence-based treatment for eating disorders, anxiety, and depression, and utilizes cognitive behavioral therapy, dialectical behavioral therapy, acceptance and commitment therapy, and holds a certificate in rational emotive behavior therapy. So thank you both for being here. We're really excited to hear from you and learn from you. And I'll toss it over to you to get us started.
Thank you. Most of the faces I see are faces that are very familiar. We talk a lot, so it's kind of neat in a way. And if anybody else joins along the way, that would be great too. I was thinking about what I would like to contribute today, and I think a lot of that will be historical, and because I think it's always good to put things in perspective, especially in forms of understanding of the problems we treat, and definitely the newer forms of treatment. So to add to what I was saying before about being in Florida since the mid-'80s, when I came down to Florida, and even in New York where I practiced, anxiety was hardly ever spoken about. And believe it or not, even then, tongue in cheek, it was only a problem that women had, and so it wasn't really taken seriously. And if you discussed it with mental health professionals and certainly with medical professionals, it was never really taken seriously. And, it was always like a little bit of a smirk or a funny comment about it, about anxiety, and it was never really taken seriously. But when I came to Florida, for different reasons, it evolved in my thoughts that anxiety is such a prominent component of all kinds of mental illness issues, that how does one not deal with it? And part of that related to the fact that the practice that I came into when I moved to Florida was practice in addictionology. The psychologist who ran the practice was a recovering alcoholic. And as a result, most of the patients that I got to see were people in recovery. And the stories, the clinical stories, the anecdotal stories were hardly ever unrelated to anxiety. Either the drinking was self-medicating for anxiety, depression as well, but I think mainly anxiety, and certainly a resultant of all of the the drinking led to anxiety as well. So it kind of became more and more obvious to me that I could contribute a lot more effectively, not only for the patients that came in because of their alcohol dependency, but in terms of perhaps in a long-term approach, preventing a certain degree of addiction and alcohol dependence by working with anxiety. And when it came to alcohol, a preponderance of the anxiety related to social anxiety. Now, we didn't necessarily call it that then, but that's really what a lot of it related to, was social anxiety. And certainly in the material working with people, they say, well, you know, I started drinking a lot when I was in high school or in college in order to be able to socialize, in order to be able to ask somebody on a date, in order to, you know, feel competent, you know, to get that social lubricant. And, you know, so a lot of the problems really related to how does one deal with their social anxiety, the social insecurities, and obviously for a certain percentage, dependency then becomes, you know, prevalent. So when I reached into the late 80s, early 90s, I attended a meeting of this organization. It was in Washington. It was called the Phobia Society of America, which we now know is the Anxiety and Depression Association of America. And it was really a great meeting. It was just really, really well done, even way back when. And it's really when I first started to kind of formulate my main interest in anxiety disorders, and kind of drifted away from really having much interest in any other clinical disorders. And at the time, and most of the patients that I got to see were panic disorder patients. And I think it was because of the nature of panic disorder. It's so intense, and whether you're avoiding or not, you're likely to be experiencing panic attacks anyway. You know, you can't run away, you can't avoid those attacks. So that would propel people to seek treatment, I think, much more aggressively than some of the other anxiety disorders that they could find ways of coping with via avoidance, like social anxiety disorder, for instance. Illness or hypochondria at the time was also on the list of anxiety disorders, but it certainly wasn't as prevalent. And a lot of that has become much more because of our media and internet and Dr. Google and the hyper awareness, excuse me, the hyper awareness of all of the diseases any minute that we could die from, whether we don't take the medicine or we do take the medicine, we're going to certainly die from something. So over the years, it's evolved, the types of anxiety disorders, but that I think are prevalent. But it was always the same concept that struck me way back when is, well, okay, what is it that we do for these patients? You know, how am I going to get this person better? And, you know, the whole concept of feel the fear and do it anyway. How do you get a person to not avoid? So, okay, I can tell that person, here's what I want you to go do. We need to do exposure. Or we can just, if we can't do that, we could use imaginal techniques. Or we could do what I guess we don't talk about much anymore, implosive techniques. So the choices were pretty rough. If you tell a patient, well, you know, we're going to get you to go out there and tough it out, and we'll be nice because we'll get a you know, kind of a systematic hierarchy. That was probably your best bet to get people to comply. But, you know, compliance was always a difficult thing because you don't really know what they were doing out there. And there were always all kinds of reasons why the person couldn't be that compliant. And if you saw the person on a weekly basis, this could take months and months and months just to get any degree of compliance with increasing levels of difficulty of exposure. So that was very frustrating. The alternative, imaginal, really, in most respects, relies on somebody to really have the ability to use their imagination in a very focused way and really stick with the imagination, as opposed to giving it a quick, yeah, I pictured it for a couple of minutes, but, you know, I don't know. I guess I felt something. So it just seemed like those two models were what we had, and implosive, which, you know, you really couldn't get anybody to do that unless they were very masochistic. So it kind of hit me that, well, this treating anxiety sounds like it shouldn't be a very difficult thing, but it really is a difficult thing because it relies on that compliance and that collaborative model. and runs into the difficulty of what is the patient going to do when they feel like they can comply. Are they going to be honest? Are they going to let you know, look, I just can't do it? Or are they going to be avoiding even talking about that lack of compliance or the difficulty they're having? And they'll just kind of flee therapy and kind of drop out. So that issue kind of lingered for a long time until another meeting that I went to of ADAA several years later. They was the first one I had ever seen, which was the virtual reality treatment of fearful flyers. It was really pretty cool. And at the time we didn't have, I mean, I don't even know. Yeah, there were computers, but nothing like anything really. So they had this big chair that was like a chair that you would sit in an airplane, and you'd put on the Oculus, and the chair would move in coordination with whatever the software was telling it to do, and you'd hear noise, and you'd sort of feel like you were in a real airplane, and you'd sort of feel like you were taking off. And it was the closest thing you could do for a patient who was afraid to fly but wasn't flying. The problem with it was, as it is with a lot of virtual reality treatment, the person can always say, well, I knew it wasn't real. So, I felt something, but I could do it because I know it's not real. And so that could make it feel like there's no value to the treatment modality. Like, well, if they know it's not real, then how is it ever going to make any difference? Or how is it going to, kind of add into the overall goal that we're trying to accomplish? But interestingly enough, there's a line, a threshold, where if it's too real, our patients are not going to do it. If it's not real enough, and that was the case earlier on, where the visuals on the virtual reality were so like cartoony like that it didn't feel like anything. So what I believe has happened over the years is that it's gotten better and better. So it feels pretty real. A few years ago, I guess my son-in-law was at the local mall with his kid, and they had Microsoft had a station there with an Oculus, and they were letting people try it out. So he tried the one where it was like, I think you were climbing a wall. And he said he was one of the most terrifying moments that he's ever had was knowing he's in the mall, knowing he's wearing an Oculus, knowing it's not real, but it felt very scary. And I said, great, I'm glad to hear that, because that means we can get our patients into situations that feel very real, although they know it's not. So that can manipulate and get patients to comply with the virtual reality part enough so that they do get the physiological arousal that Dr. Spinner will talk about, enough so that we can start to work on the response that they're getting. And so over the last few years, it's become more and more helpful because of that improvement in the software. Because compliance is really the whole thing. We know, I mean, it's not the whole thing, but it's a big chunk of helping people get beyond the intellectual understanding of their anxiety. And yeah, I know there's really no danger, but how do you get them to be able to tolerate that anxiety, the symptom tolerance? And if you can't control what goes on outside the office, chances are, because we're all so pain avoidant, chances are that person's not going to want to go out there all the time and feel horrible. And if they have a really bad version of anxiety disorder and or anything else, it may even be like, what we call iatrogenic, where we're making people worse if we put them through too much of something. So I really believe that virtual reality treatment is going to be a really bigger and bigger agent for us to use and rely on in helping people bridge where they are and getting to actual, exposure out there in the real world. I've never really been a big fan of Imaginal, except for a small percentage of people who really have the ability to do that. Now, interestingly, I always tell my patients who have any kind of anxiety is that people with anxiety have great imagination. They do, but it becomes overused in the negative. But they have the capacity to have a great imagination and to do the imagery, but it's hard to get it going. So this, I think, becomes a great tool for us. So, we have avoidance with the big A, which is avoidance of treatment, avoidance of dealing with problems, avoidance of acknowledging I have a problem. And then we have avoidance with a little a, which is, the subtle kinds of avoidance that can go on even when a person's in treatment. And I really believe that the use of virtual reality helps us with our patients with that little a and starts to give them the confidence. So with that, let me turn the details of all of that over to Dr. Spinner, because he's got the hands-on every week with actually, doing the work. Dr. Spinner.
Sure. Thank you so much. So first, I just wanted to echo Dr. Rosen's excitement in terms of how virtual reality treatment is becoming a more prominent treatment option and modality for, I think, a larger amount of mental health issues that people are facing. It's been around for a little bit now, more in the beginning, especially for, like PTSD, especially in combat situations. But as it's, become more commonplace and used for a broader range of psychological problems, especially within anxiety, I think that we're starting to see that it can be applicable for a lot of different areas. So it's a really exciting time. So what I wanted to do was first talk about the benefits and some of the issues related to virtual reality exposure treatment, and then show you all a little bit of the different features in the virtual reality program that we use here. So in terms of the benefits, there are quite a few, right? So number one is financial or cost feasibility, right? Even, when I'm seeing patients virtually, while we are able to do the virtual reality treatment, either using a smartphone or a VR headset device, I typically recommend the VR headset device as it's more immersive. Even that cost, which is not incredibly small, it's $350, I think, for the headset. It's a lot easier financially than, let's say, somebody who has an airplane, a fear of flying, right? Like having to try to buy plane tickets, or constantly using gas if it's a fear of driving. Like it's much more cost feasible in that way. In terms of the treatment itself, it offers us a lot more control and manipulation over the environments in which we're exposing them to, right? So related to social anxiety, specifically, which I'll show you all some of the environments they have shortly, we can say, oh, go into this bar and try to talk to people, right? But or in class tomorrow, try to spark up a conversation with peers or whatever it may be. But we don't know what those people's responses are going to be to them, right? And in something like this, I can manipulate, okay, they're going to get a negative response from these avatars that they're interacting with. They're going to get a positive response. They're going to get a neutral response. If it's more performance anxiety, I can manipulate the amount of people in the room. I can manipulate the amount of noise, the amount of distraction, again, the reaction, the response, different types of, again, with interpersonal interactions, the type of communication that they're having to navigate if we're working on social skills training. So I can have them interact with someone who's communicating with them aggressively, passively, assertively. And so all of those ways are helpful. And even again, to go slightly off of the social anxiety exposures, even like for phobias, right? I can, if in talking to a patient, what's most difficult for them, let's say in fear of flying, is the takeoff and the turbulence, right? I can continue to just expose them to takeoff, right? They don't have to go through a whole flight. They don't have to do the landing. They can just continue to go through takeoff. I can manipulate how much turbulence they're experiencing, what the weather is like, what time of day, and even, you know, in driving, things like putting them on a bridge, putting them in traffic, putting them in a tunnel, highways, side streets, things like that. I think another positive or benefit of virtual reality exposure is just the variety of different types of environments. So not just for social anxiety, but it's helpful even in when we're talking about social anxiety, because we know that anyone experiencing anxiety disorders, including social anxiety, it's pretty common for them to have comorbid other anxiety disorder issues. So phobias, generalized anxiety, there are a lot of different environments that we can put them in, as well as exposing them to different treatment or coping techniques. There's educational material, there's mindfulness practice, there's relaxation training, all of these sorts of things. And Dr. Rosen alluded to this a little bit in terms of the realistic nature of the virtual reality. I would say the one drawback that I've noticed in working with virtual reality exposure can be sometimes the realism of the environments. It hasn't happened often, but for example, I was referred a patient by Dr. Rosen who's had a phobia of needles. And they were already in real life getting exposed to a treatment that required them to be injected, I think at least weekly. And so putting her in this exposure where, you know, the hand or the arm that was being exposed clearly wasn't her arm, you know, a needle that was only so detailed, you know, it did not bring about the amount of arousal in her that it was going to be as effective as maybe would have been, you know, ideal for treatment. But for the most part, from just my work with it, that hasn't been so much of an issue. But if I was going to pinpoint the largest drawback, that's what I would say for me so far in working with virtual reality, it's been. So with that, I wanted to share my, it says that the host disabled participant screen sharing. So
All right, I can turn that on. Let's see. All participants. Okay. Right now.
And that actually reminds me, before I get into that, the one other important benefit I wanted to talk about was the ability to monitor the patient's experience. So one, and I'll show you, I did one just so you could see it beforehand. Before we joined this meeting, I ran through one for a few minutes, and where I put myself in an auditorium where I was giving a speech. So there's two main ways that we monitor the patient's distress level. And one is using their SUDS rating, which we can ask them by clicking a button asking for their SUDS, and they identify it from 10 to 0. And you can see over time, I made it. So my fake SUDS went down a little bit. So you can see I just did 3 data points here. And the other way in which we measure their arousal level over time is through some like biofeedback of an electrodermal response sensor. So these go on fingers and they sort of show a heat map throughout. So you can see here the difference in my arousal, although it pretty much stayed the same. I didn't do it for very long. Again, this was just sort of to illustrate what it can look like. But so most of the time, or what you would hope, is that as their studs goes down, also the amount of heat would also go down in their bodies, because a lot of times one of the physical, manifestations of anxiety is that increased, heat, and can be manifested as sweating or redness or things like that. So then in terms of the different environments that they have, so lots of different ones, like I said. I wanted to pinpoint a couple that are specific to sort of our talk today in terms of social anxiety. So in terms of social situations, we have two environments. And actually what I wanted to do was I'm going to turn the VR headset on so that we can actually go into one of these environments rather than just watching a YouTube video. So you can see the different ways that I can manipulate the environment. Yeah, that's fine. Go back. We'll do the chatting at the bar. Hang on, I gotta wait for it to turn on. Just 1 second. Sorry about this. It's just about to be connected. There we go. Launching the environment. Okay, so you can also assign. So with patients, they have like their own. That's how I accessed a report. They can each have their own sort of file in the system. Just downloading. So down here, certain things. So this is where I would ask like the subjective units of distress, and it would come up on their screen, the number line for them to choose from. Down here, configuration, I can change it from if they're going to be friendly, if they're going to be sort of rude, standoffish. Let's see, will it let me? No. Yeah, so friendly or rude is what it looks like. It said it before, but now I can't bring it up. There we go, friendly or rude. So it would start, so you'll see what they're seeing. Environment ready to start. This is also, I would say, one of the drawbacks sometimes, little technical difficulties at times. But here are different things that I can do. Make an order, ask for the bathroom, regulate the temperature in the room. Oh, sorry, I don't know if you probably can't hear that, but if you can, they're around a bunch of people and they're having a conversation. Other things you can manipulate if you wanted to make it if what they struggle with is the physical sensations, you can have it so in their ear they hear a heartbeat or breathing rate to elicit some anxious arousal. There are also different audio guides, like to remind them to practice some diaphragmatic breathing, progressive muscle relaxation, thought management, catastrophizing, downward arrow, things like that. And so this is what they're seeing. I can look around. I don't know if it's okay. And then I wanted to show at least one more. I just wanted to show one for, because another common component that a lot of people experience with social anxiety is that performance aspect of it. So I wanted to, which there are a few more environments for that in here. Oh. Sorry, I'm just glad it's honestly working at all. The internet was not playing nice with me earlier today, so I'm glad it's at least sort of loading, even if it's a no. Sorry, everybody. Hey, you know what? We're gonna do this. Sorry.
You're almost always guaranteed some tech challenges when you do live demos.
I'm just gonna reload it. That's easier. um, I definitely have seen the realism in some of these. When I was first learning how to use this platform, I took the device with me and was playing around with it at home, and I had my wife put it on, and I did a height exposure, and she was like, wait, maybe I'm afraid of heights because I am very nervous right now. Okay.
What's good is that since COVID, the technology allows people to do it from home as opposed to being in the office. It was really, that's been a big help.
Well, while this is loading, there was something to mention.
I've been curious about being able to.
Well, I'll just sort of, hopefully this will load, but if not, I wanted to at least describe the other environments that we use with, or that pertain to social anxiety specifically, sorry. And that's, so for the performance anxiety, they have things like speaking in front of an audience, speaking in an auditorium full of people, at a streaming conference, and at an office scene, as well as those other two that I mentioned before in the social. So either in that bar or on like a terrace. Sorry, we're gonna give it one more try.
And Dr. Spinner, while you're working on that,
I don't know what's also going on. I can't hear. I saw Dr. Rosen was speaking before. I couldn't hear him. And Taylor, I can't hear you. I don't know why not.
Well, I can chat to you. Let's see.
Okay, it keeps just going into this, so this clearly isn't going to work. Sorry, everybody. But at least you got to see it once for a little bit. Oh, chat. Oh, we can hear. Good. I'm glad you can hear me. Let's see. Okay, now it's working with me. So going into public speaking, let's do auditorium. Yeah, just pause. That's there. There we go. Okay. So again, I can change the amount of people in the room, the gender variability of the audience, the difficulty of getting these to work. Then again, I can change the type of questions people are asking. So like things like, I can do positive questions from the crowd, negative questions. You can have different distractors. So we can have people yawning, having people applaud, having people leave, get up and leave during what they need to say.
Problems.
Okay. Well, let's I'm gonna just show you guys in this way. You may not be able to hear anything, but you'll at least see a demo video of what this sort of looks like. So you start in the crowd, then you eventually go up on the lectern. There's a little iPad there. This person is asking a question. Okay. Another question. All right. So, and the last thing I just wanted to mention before finishing up was just a little bit more about my experience with it. I have used the virtual reality for a few patients related to social anxiety, especially with the performance-based anxiety. And I think what's also been great about it, again, is working with those different comorbid anxiety issues, as a lot of the times where I've used it has also been in things like fear of flying, fear of driving, claustrophobia, so or being around large crowds. Broad question. Exposures from a learning or social. So I think it depends, Daniel, on what their primary, how that the social anxiety is manifested with them. If it, I think when I would think, or I wouldn't, I would say with social anxiety, a lot of it is going to be that, like, disconfirming their maybe negative hypotheses about what's going to happen or what it's going to be like, or those social judgments. I would say when it's more of the phobia or even with panic, where it's the physical sensations themselves that is prompting that anxiety, I think that habituation and desensitization of those physical responses and just the adjustment to the feared stimuli is going to be a focal point there. But I think, you can work with both. And I think that's, true a lot of the times when you're dealing with exposures, whether it's imaginal, in vivo, virtual. And that's why I think something like this is great, that even, comes with things like, decatastrophizing, downward arrow, things that are more cognitively focused versus some of the tools that we use in virtual exposure that are more just physiologically focused and habituation driven.
I would add, Daniel, to that, with
There we go.
avoidance
Now I
of
can hear
any
you guys.
type, with avoidance of any type comes the actual inability to find out that if A, B, or C happened, that feared event or that feared comment or that feared experience, if it were to happen, I wouldn't be able to cope. I wouldn't survive that. I would be. And so these kinds of experiences, even in VR, you might, like with a lecture where somebody's kind of nasty or asking a question, or you forget something, or you experience that embarrassing moment, you find out I could deal with it.
Mhm.
If it were
Yeah.
to happen, I can deal with it. And that's where, I always tell, I'm sure we all tell this to people, you get confidence from having gone through something negative, not through getting through something positive. So,
Mhm.
these offer you the opportunity to hear the worst case scenarios actually happening. So
Yeah.
to me, that's that's the disconfirming aspect of it.
Yeah, well, and that's why I said they're sort of interconnected, because I
Mhm.
think, even the disconfirming the belief that, like, this physical arousal will not go away, right? Because we know when people are avoiding that anxiety, they typically bail out before they're able to get on the other side of that peak of anxiety. So they never really get to see that habituation, or that it does go away or lessen. So in doing that and exposing them through the entire anxiety experience to where they can see that back end and it's starting to decrease, that sort of serves to disconfirm some of the beliefs they have even about their own experience with anxiety, or like Dr. Rosen said, with their ability to cope with anxiety. So I think they sort of work together. Like that habituation process helps to disconfirm some perspectives that they might have. No. They do. So the question was, does the client have to purchase the VR headset in order to do the treatment remotely? They don't. They can utilize an app on their phone and buy a sort of like shell of a VR device where that has like a place for your phone. I will say, like I said earlier, I still encourage, if they're able to get the VR headset, only because our iPhones don't have the capability to really configure like a three-dimensional image. So while it's still like in front of their face and they do experience some level of immersion and virtual reality in that way, it's not as immersive as like a 360 degrees, like three-dimensional immersive experience. But I have worked with patients that have just gotten or used the app on their phone and bought like the shells, and they are much cheaper, as is pointed out in the chat. So that is, no, you can do it either way. The other good thing, oh, I'm so sorry. I just wanted to say the other good thing about this is whether it's on the phone or the headset, you can also enable their device for homework. The homework really only unlocks some practice with coping, so you can engage with the relaxation modules and the mindfulness modules, not the exposures themselves, but you know, at least they're getting one exposure to being in virtual reality in between sessions, and also getting more exposure with practicing some of those physical and cognitive coping techniques. Sorry, Taylor, go ahead.
No worries. I was just going to pop in and say, it sounds like we're sort of transitioning to question and answer, but so I just want to check in with you both, Andy and Eric, to see if there's anything more that you wanted to talk about, or whether this made sense to jump into question and answer time.
No, the Q&A is fine. I think that's helpful. I would just add that in terms of virtual reality in general, you know, when I first got interested in finding out about where I could access virtual reality, I did a fair amount of research over a period of 6 months, and I got very excited right away about this, getting virtual reality from this startup out in California in Silicon Valley. It was like, and they were doing some really great work and developing all kinds of new software. But to do it, it meant like it was about a $15,000 investment, and with the promise that they were going to keep developing new protocols. So I'm like, well, I don't know that, you know, sometimes I get impulsive like that. So, but I'm going to hold. So I did some more research and found this company that's in Spain, which is now Emilia, and they, at the time, it was a completely different model. They had been infused with a lot of private equity money, and there was no initial purchase. There was you buy into like a yearly package, I think it was, and they had already developed a bunch of protocols, and you could see the movement. And just in, I don't even know how many years it is now. I guess it's about 4 or 5, maybe 5 years. The amount of improvement and development of new protocols has really been pretty cool. Not just about the exposure part of it, but like what Eric was saying, the supportive things and the teaching things and the other things that patients can derive from it, including, when they're not actually in session and paying for session, they can do a lot of work outside of their sessions. So it's really pretty cool stuff.
And I'm so sorry. I was just going to say, and they've even started going beyond anxiety disorders. I don't know if everyone was able to see like all the different environments briefly when I had it on the page, but they have one for substance use recovery, for attention training, for eating disorders. So they're starting to branch out even to a broader range of issues.
Yeah, I think the eating disorders one is going to be pretty good because it gives people a chance to expose to situations that they'll have to encounter. Just a real quick funny story to add to this, because I was just thinking about it when you were talking about the flying phobia. This goes back, it was just before COVID, I guess maybe 6 months before. So Dr. Seidman, who's our director of our Children's Center, and Dr. Gross, my partner, who is our medical director, we were invited over to the Rogers program in Tampa. And so we were going to fly over just for the day from Fort Lauderdale. And but Dr. Seidman is definitely ranks up there as a flying phobic. So for a couple of weeks before, I was, doing some quasi-therapeutic stuff with her, trying to do some CBT and exposure things. And we even had her, it wasn't Dr. Spinner at the time, had her do some virtual reality. And she was pretty, she was really nervous, but she sat across the aisle from me right over, just, in case she needed some extra hand holding. And this is the part that wasn't virtual reality. So we're going down the runway, taking off from Fort Lauderdale, and just as you lift off from the runway and the wheels up, the cockpit door was not locked well, and it popped open with a huge bang. And she got, wow, she said, "Is this part of your virtual reality now?" But she said it was much more effective than the virtual reality was. Got her right to the top of whatever physiological arousal we could measure.
And now from there on out, she can say, well, I lived through that.
Exactly.
There you go. Even like in line with that, I would say one of the other things that I forgot to mention, and obviously you're constrained by your own environment, but how I've seen that can be helpful and even supplementing the virtual reality experience to make it more immersive is adding any real life components that you can using like senses, right? So if they're in an exposure environment that would usually be accompanied by a certain smell, if you can get it from a candle, or if it's like an outdoor smell, like putting that into the exposure, or if it's a height exposure and there's one in the environment where you're outside the building on like a sort of freight elevator, opening a window by them so that the wind is blowing and they feel it, or even with the plane when there's turbulence, if they're in like a sort of a rolly chair, sort of moving the chair a little bit, so it's not just their vision that's sort of shaking, but a little bit more realistic.
Right.
But yeah. Q&A.
It's just another modality that helps us. Go ahead, Lauren. I'm sorry.
Oh, can you hear me? Oh, that's okay. So this is really interesting timing because we had Amelia come out to our office about like 3 weeks ago for a demo. And I guess you sort of already answered this, but some of our staff that were part of the demo were concerned that it just wasn't realistic enough, but it sounds like that's not something that comes up a whole lot for the clients.
I don't
think if it comes up, it's not in a way where it's discredited or not helpful. It's okay. And if it does come up, I think the way to approach it is this is exactly what enables us to do this, and get you to the next step, which is this is the final step. This is to get you to be able to do in vivo.
Yeah. Okay. Do you know any of are there lots of other competitors in the market right now? I'm like, this is all really new to me.
Yeah, I have not checked lately, but I know early on there were, and I guess it's like anything. I mean, some will survive and some didn't. But I think in terms of availability and cost, et cetera, for clinicians, it's this type. I mean, I haven't compared it to anything lately, but I'm satisfied with it.
I did think it was pretty affordable, so that's a good.
Yeah. It is.
Option. Yeah.
Yeah. And I would even say for the clients, it's even if they were to get the headset, it's reasonably affordable in that they don't have to, it's the practice that pays like the monthly subscription so that they're able to use it. So that's not a fee that they have to pay. They just have to pay for the device, whether it's just downloading the app on their phone and getting that shell or getting the VR headset. And that's sort of the only cost other than the sessions, obviously, that they have to worry about.
I have a client, so I'm gonna get going, but I do have a couple of remarks. I tried this out. We were using the shell with the phone, and the concern that we had at the time was the phone we were using got very, very hot. And I didn't want it to blow up in somebody's face. That bothered me. But that was just an example. But I'm also wondering about the research as they are expanding and they're adding in things like attention trainers. There's some question I have about the research on attention trainers. Some of the relaxation modules, do they have a research page that we could look up things before we added to the treatment protocol?
I would see. I'm pretty sure there is, but I haven't not accessed it at all lately. So, but I would imagine from the website there's data that they have.
Okay.
Yeah, I'm not sure if they have such specific data for like the individual different like interventions or environments, like the attention focus specifically. They definitely, in terms of, they have a whole academy tab on the side to help like a new clinician who's using it utilize the device, but also like learn about the whole process and how it came to be about. And there's definitely research cited in those documents. I'm not sure that they go into specifics of like the attention specifically, but they definitely have research on their website that talks about the effectiveness of the VR program. Someone asked a question about you using it with children or adolescent clients. I have not had the opportunity to use it with an adolescent or a child as of yet. I think that I'm not sure about the difference in buy-in. That was sort of the part 2 of that question. I think, I think it all depends. One, I think like Dr. Rosen said, on sort of the imagination, I think a little bit, even though it's not an imaginal exposure, to sort of be able to look past the maybe sometimes cartoonish look of some of the things and really try to buy in. And I think a couple of ways that I try to increase that buy-in is one, like Dr. Rosen said, of specifying it as a stepping stone to like in vivo, and that this is not like the last step, but also encouraging them to, when those thoughts come up, to try to disengage with those, right? Because they can be seen as a type of avoidance, right? If you're reassuring yourself and reminding yourself, oh, well, this is fake, I'm safe, this isn't real, that's sort of a little a, like to use Dr. Rosen's terminology of like the covert avoidance of like you're avoiding fully experiencing the full effect of what your anxiety would be if you allowed yourself to be fully immersed in the environment. So to sort of normalize that experience for them, but also encourage them to try their best to let go of those judgments.
You have to get into it, The funny story, years ago, I was at the movies with my wife and a bunch of the kids to one of the Tom Cruise movies, where he was doing all his tricks and everything. And at that really intense moment, you heard my wife say, "What a lie." It's like, don't say that in the middle of it. But you have to get into it. And some kids I think kids love VR. I mean, obviously. So I think they take to it, but they might dismiss it feeling like it's not really good VR or something. It's not fun VR. But well, it's helpful.
Well, and Lauren, I think that to your point of like competition, I'm not sure about competition right now either, but I can only imagine it's going to greatly expand at some point in that the headset for this company can just be used for this, and it's like a whole process in getting it, whereas like the Oculus that's becoming, just used by so many people, or even like for PlayStation, for example, you can get a headset for virtual reality playing video games. I can only imagine that those companies would eventually want to add that for the benefit of, sales and mental health and all of those sorts of things. And it's more accessible than something like this, which, most clients would have never heard of this company, whereas Oculus or, PlayStation is something that most people know or have heard of.
Wonderful. Well, thank you all so much. I'm realizing we're about at time. So I'll wrap us up, but I'll make sure that folks have your contact information for any additional questions. And thank you. This has been really
Great.
informative, really great to see the demonstration, to see what it looks like and how it can work, and really impressive to see how far it's come as well. And great to see how it can really be tailored for the work that we do with people with social anxiety.
Great. Thanks for having us.